All right. Thank you, everyone. Good morning, good afternoon, good evening across the world. It's so wonderful to have an opportunity to present to you today. We want to present this topic of herb-drug interactions, and I'm very pleased to be the initial host today. My name is Amy Rowe. I'm a principal toxicologist at the Procter & Gamble Company. And here is the agenda for today. I know that you all have probably seen this since you were able to register for this webinar. So I'm not going to go in detail and share and introduce the speakers and share the titles. I will let them do that themselves. And I want to give a special thank you to my colleague, Dr. Helen Okech-Raba, who helped organize this topic for today. She's with the United States Pharmacopoeia, and hopefully she was able to join this morning. So with that, I'm going to stop sharing, and I'm going to turn it over to our first speaker. And after he is done presenting, hopefully we'll have time for a couple of questions, and just raise your hand in the chat. I'll monitor for that and call you out by name to ask your question. And then hopefully at the very end, maybe we'll have some additional time to have questions of any of the speakers. So with that, Josh.
Thank you. So again, thank you to the organizers for inviting us to present some of our work that is done through the Natural Product Drug Interaction Center, headed up by Mary Payne at the Washington State University. I'm actually at the University of Washington in the Department of Pharmaceutics. I'm a professor there. And we've been collaborating with Mary Payne and others in the center, investigating the in vivo cannabinoid drug interactions. And the title of my presentation is Getting into the Weeds. Just a little bit of a pun on the title there. Just to give you some introduction in terms of why we're interested in this, and a bit of an outline of my presentation. So I'll speak a little bit about the prevalence of marijuana or cannabis use in the United States. And then I'll speak a little bit about the in vivo evaluation of cannabinoid drug interaction study that we've been doing in collaboration with a group at Johns Hopkins University. And then I'll talk about, whether we can predict these drug interactions that we've been observing in vivo through physiologically based pharmacokinetic modeling. Now, before I go any further, I want to say at the outset that that basically all the work was done by Sumit Bansal, a postdoc in my laboratory. He's otherwise preoccupied right now, and that's why he's not presenting and I'm presenting. And he was aided in some of the PBPK work by another postdoc in my laboratory, Mayur Ladumore. So credit should really be given to these two individuals for the majority of the work that I'm going to present. Now, why is there a concern about drug interactions with respect to marijuana use, either for recreational or medicinal purposes? Okay. And the reason is that there are some cannabinoids that are present in large quantities in marijuana, such as THC, and also in some instances cannabidiol, that have the potential to interact with FDA-approved drugs or other supplements. And there is evidence in the literature that at least cannabidiol could be a potent interactant with respect to metabolism of other drugs mediated primarily by cytochrome P450 enzymes. So we've done a series of studies, and I'm not going to go over these studies because of the time constraints. We've done a series of studies with human liver microsomes and recombinant enzymes. The human liver microsomes were really designed to study the interactions of these cannabinoids with cytochrome P450 enzymes. The recombinant enzymes were targeted primarily to study the interaction of these cannabinoids with UGTs. And what we found is that CBD is actually a potent reversible inhibitor of multiple cytochrome P450s, and also a time-dependent inhibitor of CYP1A2, 2C19, and 3A. So time-dependent inhibition means that the inhibition, basically is, as the name says, time-dependent. And often these type-dependent inhibitors are not because of metabolite that is produced by the perpetrator, in this case CBD, but potentially by inactivation of the enzyme. And from these in vitro data, we predicted that oral CBD at about 700 milligrams dose was predicted to precipitate in vivo drug interactions with medicinal compounds that would be metabolized by CYP1A2, 2C9, but more importantly, 2C19, 2D6, and more importantly, 3A metabolized drugs. But what we found is that THC is also an inhibitor of many of these enzymes. But when we did the in vivo predictions based upon these in vitro data, we found that at the doses and the concentrations that would be achieved in the plasma of THC, there would be primarily be a modest, if at all, inhibitor of 2C9 metabolized enzymes. And then both CBD and THC also showed inhibition of several UGTs. But again, our predictions based upon the IC50 values, as well as the in vivo concentrations achieved of these two cannabinoids, that only oral CBD was predicted to precipitate moderate to strong interactions with these substrates. Okay. Now, I just want to point out is that currently there is no data in the literature that corroborates our findings. And also much of the data on cytochrome P450 was also in vivo data I'm talking about is not available to see whether our findings are quantitatively accurate. Therefore, we set out to ask the question, do these predicted interactions based upon in vitro studies actually occur in vivo? So this is a clinical study that was conducted at Johns Hopkins University by Dr. Ryan Vandre and his team. So this is a collaboration with Johns Hopkins University of the NAPDI team based at the Washington State University and University of Washington. And this is a double-blind randomized crossover design study in healthy adults. There was 18 subjects. And basically, the design of the study was as follows. The subjects would come in, get a breakfast, and 1 hour later, they would get a brownie. Now, that brownie would contain either a cannabis extract containing THC of 20 milligrams, or a cannabis extract containing CBD at 640 milligrams, and THC also at 20 milligrams. And then 30 minutes, or placebo. So it could be either one of these three treatments. Okay. And then 30 minutes later, they would get a cocktail of cytochrome P450 probe drugs. So what do I mean by probe drugs? Probe drugs means that their pharmacokinetics in vivo would then report the activity of different enzymes. So caffeine would report the activity of cytochrome P451A2, omeprazole would report the activity of CYP2C19, and losartan of 2C9, and dextromethorphan of 2D6, and midazolam of 3A. So all these were, of course, given orally as well. Now, if the subject received the THC brownie, then they would come in again after a washout of 1 week. So there would be a 1 week washout, and they would get this in a randomized manner, another brownie. It could be a placebo or the CBD and THC brownie, and so forth, until all three treatment arms have been completed. And then what we also did was we collected blood and urine from 0 to 24 hour post the probe cocktail administration, and then pharmacodynamics measurements were taken over 24 hours. So each subject went through these 3 treatments in a randomized crossover manner. So I don't have the time to go through the results obtained for each probe cocktail drug in terms of the impact of THC or CBD plus THC on the kinetics of these probe drugs. So I'm just going to summarize for you the findings. And I'll show you a summary graph as well in a few moments of the findings. So what we found, as we had predicted based upon in vitro data, that CBD significantly inhibits cytochrome P52C9, which is the primary enzyme metabolizing THC to 11-hydroxy THC. And 11-hydroxy THC is also an active metabolite. So what happened was that the CBD, when given in combination with THC, as opposed to THC alone, increased the AUC of THC from 0 to tau, it was basically 0 to 24 hours, by about 2.7-fold. But surprisingly, even though CBD inhibits THC metabolism to 11-hydroxy via 2C9, it also increased the 11-hydroxy THC 0 to 24 hours by about 3.8-fold, indicating sequential inhibition of sequential metabolism of 11-hydroxy to the carboxy and to the glucuronide of 11-hydroxy. And interestingly enough, and I'm not going to show you this data, this resulted in a greater pharmacodynamic effect of THC, indicating that this interaction results in a change at the level of the pharmacodynamic response of THC. Now, we also found, because we gave in the cocktail other probes that were probing other enzymes, including 2C9, that indeed THC plus CBD significantly inhibit the 2C9 probe, but also the 1A2 probe and 2C19 and 3A, indicating that that CBD was inhibiting all these enzymes because THC alone did not produce those interactions. And, our data suggests that THC plus CBD, and here CBD is playing the dominant role, and it's not THC that's playing a role, significantly inhibited UGT1A9, 2B4, and 2B7, explaining some of these data of the elevation of the 11-hydroxy THC concentrations, but also some of the sequential metabolism of the probe drugs. So now what I want to do is to turn to the question of, can these interactions be predicted by PBPK modeling and simulations? So we set up a CBD model and validated it using different studies that have been published of CBD, including fed and fasted status, where the absorption of CBD changes substantially. And then we applied this model, including the in vitro data on inhibition, reversible as well as time-dependent inactivation of various cytochrome P450s and the reversible inhibition of UGTs. And then we asked the question whether we could have predicted these interactions. Okay, so what you see here on the y-axis is the area under the curve geometric mean ratio, meaning this is the change in the AUC of the probe drugs as well as THC, and in the absence and presence of the THC plus CBD arm. Okay. So this is compared to the placebo arm. So if there's a change in the AUC, then we take the geometric mean of that change and take the ratio of that change. And as I showed you earlier, THC AUC ratio, geometric mean ratio, increased by about 2.7-fold. Okay, so that's the observed. I'm sorry, the blue bar is the observed data, as well as the standard deviation, and the magenta bar shows the values that we're predicting through PBPK modeling and simulation, which is showing very, very good prediction of the interaction of CBD with THC. Now, of course, we had another drug that probed cytochrome P52C9 in our cocktail, losartan, and that too, as you can see, is predicting relatively well. The magenta bar are the predictions, and the blue bars are the observed values. Now, what about the 2C19 interaction as probed by omeprazole? Again, we are predicting, more or less right on the interactions that we observed with omeprazole. Okay, and of course, these predictions are all based upon the in vitro studies that we've done with human liver microsomes. With human liver microsomes. And then here are the data on cytochrome P453A probe, midazolam. Again, very good predictions. However, for caffeine, which probes for 1A2, our predictions suggests a greater interaction than what we actually observed, and we're still mulling over this data and sort of asking ourselves why the predictions for the CYP1A2 interactions is over predicted. And then for dextromethorphan, where we really didn't see much of an interaction, that is exactly what we predict based upon our in vitro data. Okay. So then we asked the question, since we are predicting so well, at least for all the probes except for the caffeine, whether these interactions would change on chronic administration of CBD, because of course many people take CBD on a chronic manner. And so here is the magenta bar now showing the single dose administration of CBD predictions, and the green bar are the predictions based upon multiple dose administration. Of course, we didn't do the multiple dose study, and therefore we cannot validate our predictions from observed data, but we wanted to project and predict what would happen if we gave CBD in a chronic manner. And this is an important question to address because CBD is found to be a time-dependent inactivator. So for example, if it was a mechanism-based inhibitor of these enzymes, of some of these enzymes at least, then on chronic administration, that inactivation would be increased with time. And indeed, that's what we find, is that we predict that because CBD appears to be a time-dependent inhibitor of 2C19, that our predictions are that it would, on chronic administration, produce even a greater interaction than what we observed with the single dose. Likewise, for the other enzyme, that it is a time-dependent inhibitor, 3A. And for CYP1A2, of course, we're over-predicting because we over-predicted for a single dose, and we're predicting that there would be even greater interaction with a chronic administration of CBD. And CYP26, of course, we're saying that there would be virtually no interaction. Okay. And 2C9 is not inhibited by CBD in a time-dependent manner, and therefore we predicted the same level of interaction for either losartan or THC, which both actually are acting as probes of 2C9. So major takeaways from these studies is that CBD increased THC 11-hydroxy AUC and resulted in a greater pharmacodynamic effect. So our findings and our PBPK modeling can be used to optimize the content of CBD in cannabis products to eliminate potential of this interaction. And THC plus CBD inhibited in vivo CYP1A2, 2C9, 2C19, and 3 activities, whereas THC alone actually only modestly, and I would say not significantly, inhibited 2C9 activity. Okay. And these findings can guide dose adjustments of pharmaceutical drugs when co-consumed with cannabis products that include CBD. And I'm not showing you this data, but what we found is that CBD inhibited UGT activity, but a standalone clinical study using UGT probes is warranted to validate the predictions that we've made. And I also showed you successful prediction of 2C9, 2C19, 2D6, and 3A-mediated CBD interactions. And these can be extrapolated to predict interactions with different combination of THC and CBD doses, and to predict PK in special populations, including hepatically impaired and pediatric populations. And actually, we've done the latter already, and a manuscript has been reviewed by one of the journals, and we're just responding to the comments of the reviewers. And I would be remiss in not saying that this is a team effort. Sumit Bansal and Mayula Dumar did most of the experimental work and the modeling work. But of course, this was done in collaboration with Mary Payne at Washington State University, who heads up the NAPDI grant, and Ryan Vandre at Johns Hopkins University, and their teams, and the Johns Hopkins team is sort of listed here at the bottom. And of course, thank you for NIH for supporting the NAPDI grant. And some of this work was also supported by program project grant that I head up at the University of Washington, funded by the National Institutes of Drug Abuse. Okay, thank you. I'd be happy to answer questions.
Thank you, Josh. It looks like we have one question in the chat. Why was CBD used at 640 milligrams? Usually it's used from 100 to 200 milligrams.
Right. That's a really good question. So what we wanted to do was to, first of all, let me just say that the reason why we're using extracts is because this is a natural product interaction grant that is funded by NCCIH, and therefore we wanted to use the natural products rather than synthetic CBD and THC. Okay. Now the second, to answer the question about why did we use 640 milligrams, because CBD is also used for medicinal purposes. And for medicinal purposes, for example, in the case of epilepsy, the doses used are even higher. They're like about 1,200 milligrams at the maximum. Okay. So we wanted to use some sort of a dose that would actually show an interaction, and that would also apply to the medicinal use of CBD. And there's a lot of medicinal use over the counter of CBD, that's not necessarily by prescription. And so that was the reason why we wanted to do that. And we also knew that we could develop a PK model and then extrapolate from that higher dose to lower doses. And that's what we've been able to do.
Okay, and another quick question. Which program did you use for the PBPK modeling for the predictions?
Good question. So we're using SimSep by Certara.
Great. Thank you, Josh. If you want to stop presenting, and
sure.
John can start, and we'll move on to the next presentation.